The skin is the largest organ of the human body. During an individual's lifespan, there may be periods of enhanced skin vulnerability, which renders the individual more prone to the development of certain skin problems. Critical phases are very early in life, when the skin is not fully matured, when individuals are suffering from dermatological or other systemic or chronic diseases, at advanced age, and at the end of life. The International Skin Care Advisory Panel identified key knowledge gaps in the prevention and the management of skin problems in these critical phases to improve practice and to improve clinical outcomes. ISTEP recognized a need for guidance that focuses on shared risk factors and preventative strategies for common skin conditions faced by individuals with increased skin vulnerability, such as skin tears, pressure ulcers, moisture-associated skin damage or MASD, and skin changes at the end of life. Early 2020, before the corona pandemic, WUWHS International and ISTEP launched a document aiming to define the concepts related to skin vulnerability and to guide clinicians in their efforts to identify shared risk factors and ways to maintain and promote skin integrity. The intention was not to summarize individual skin conditions, but it was to bring together by focusing on common risk factors and formulating a synergistic prevention approach that will break down barriers in practice. ISTEP brought together a group of international experts in October 2019 to discuss this new approach and to agree on best practice recommendations that will guide practice and improve outcomes. The formal launch of the document was planned at the 2020 conference of the World Union of Wound Healing Societies in Abu Dhabi, but Corona spoiled the party. As this important document provides healthcare professionals essential resources to deliver appropriate care to individuals at risk with fragile skin, we decided to launch the document in a virtual event. Today's one-hour webinar will be a teaser of what is in the full document, and it also can be considered as an invitation to a half-day webinar that ISTEP is going to organize in March 2021. More information will follow soon, so please keep an eye on our website, istep.org. We would like to thank our partners, WUWHS International, 3M, Medline, Mölnlycke and Polymem, for the support to develop this document. A special thanks go to 3M, Essity and Mölnlycke to support this virtual launch. A big thank you also goes to Kimberly LeBlanc, Troy Curtis and Kathy Harley from the Nurses Specialized in Wounds, Ostomy and Continence Canada. Thank you as well to our excellent speakers for their kindness to share their knowledge with the international community. So for now, enjoy learning with ISTEP.
Hello everyone, my name is Karen Campbell and I'm the past president of the International Skin Care Advisory Panel. I'm also a registered nurse and a nurse specializing in wound ostomy continence in Canada. I'm going to be talking to you today about concepts related to skin vulnerability. Thank you so much for joining us today in this very important webinar. What I'm hoping to talk to you about today is to define concepts related to skin vulnerability, identify shared risk factors for skin conditions, and way to maintain or promote skin integrity. By doing this, we want to eliminate silos of care. And our intention is not to summarize individual skin conditions such as pressure injuries, pressure ulcers, skin tears, as these already exist in the literature. but focus on common risk factors and formulate a synergistic prevention program that will break down barriers to care. So just to give you a little bit of background, there is a lack of cohesive terminology and definitions around skin vulnerability and the concept of skin integrity. And a formal definition is lacking so far. And our working group suggested that skin frailty be the umbrella term for at-risk vulnerable skin. And we want to do this to show a paradigm shift to a more comprehensive thinking around the concept of skin frailty, rather than clinicians thinking about, oh, I need to prevent skin tears, oh, I need to prevent pressure injuries. We want to have a cohesive approach that will help with skin integrity, skin frailty for a number of skin issues. And we're hoping that this proactive approach will protect frail skin and prevent damage in people and allow them to maintain their own skin integrity. We don't want you to confuse skin frailty with the overall concept of frailty. And the exact definition of frailty has not been reached in the literature, but it is seen as a health condition of decreased functional reserves, leading to a vulnerable state with risk for a multitude of adverse outcomes, including placement in aged care, long-term care, as well as death. And while skin frailty may be associated with aging, it does not only apply to older individuals and nor should it be seen as purely as a result of aging. Rather, it is multifactorial and is the result of cumulative effects of a combination of intrinsic and extrinsic factors. And within those intrinsic and extrinsic risk factors, some may be modifiable and some may not. And we would like you to focus on a comprehensive assessment and then a prevention plan looking at modifiable risk factors. This is a chart taken from WUWHS UK, and I'm not going to go over it in great detail, but it just shows you some of the patient groups that are at risk for skin frailty. So obviously older adults, individuals with mobility issues or paralysis, as we know that skin that is deinnervated works and functions differently than innervated skin. It can also be in children or neonates, individuals with spinal bifida, cerebral palsy, bariatric patients, oncology patients, and then a multitude of chronic illnesses and other issues that can include things like cardiovascular disease, diabetes, medication, malnutrition, and so on. And I put this picture here because this is the patient population that I work with. And it tends to be a geriatric group with a multitude of health conditions. And you can see then that these patients are quite vulnerable for skin frailty issues. So factors that make skin vulnerable to injury can classify as being extrinsic and intrinsic. And some of the extrinsic factors include environmental damage from regular use of bar soap, sun exposure, smoking, or pressure. And some of the intrinsic factors include things like aging and the effects of chronic skin conditions on the skin, so things like psoriasis or atopic eczema, as well as underlying medical diseases. And the risk of skin frailty may change for different individuals at different times. And it's vital to assess and reassess individuals, and a step should be taken to reduce the individual's risk. Now, this diagram I find very, very helpful because it focuses on a variety of risk factors and how these risk factors can synergistically actually increase the risk. So if an individual's skin has enhanced vulnerability, they are at increased risk of damage. And this may encompass a range of issues, but it's not limited to skin tears, pressure ulcers or injuries, moisture-associated skin damage, and skin changes at end of life, although our document does focus on these issues. And again, this diagram just helps me to realize that these risk factors can synergistically work together to cause skin frailty issues, but at the same time, we can target with interventions these risk factors to break that cycle. So when the risk framework was developed, considerations on the concept of skin frailty, we wanted to encompass an integrated approach that approached the skin as a whole and incorporated these synergistic risk factors that were linked to the individual's overall health and well-being. And as I said before, the conditions may relate to skin frailty include, but are not limited to, skin tears, pressure ulcers, moisture-associated skin damage, and skin changes at end of life. And we do acknowledge there may be other conditions related to skin frailty. However, the evidence base for these four major conditions is stronger. And acceptance that there is a synergistic relationship between these factors can help to optimize outcomes for patients and ensure that skin health is a focus and a risk for all these conditions. Now, this is the skin safety model that we used, and this is work done by Jill Campbell in Australia for her PhD, and it is excellent because it identifies potential contributing factors, and it looks at things like patient factors, situational stresses, system factors, and potential contributing factors. And then when you add in exacerbating elements such as skin irritants, pressure, shear, friction, then you realize that in combination with contributing factors, there is a potential for skin injury. And she actually even identified medical adhesive related skin damage as one of her other potential skin injuries. And then some of the potential outcomes of skin injuries are chronic wounds, pain, impaired quality of life, increased cost, increased length of stay, and death. So in summary, we tried to identify shared risk factors for skin conditions and ways to maintain or promote skin integrity. And by doing this, we're hoping to eliminate silos of care and focus on common risk factors and formulate a synergistic prevention program that will break down these barriers. I'm just going to show you the reference and close off my session for today. Thank you.
Hello, and thank you for taking the time to listen to this presentation. My name is Samantha Holloway, and I'm the President-elect of the International Skin Tear Advisory Panel. I work as a reader in the Centre for Medical Education, which is based in the School of Medicine in Cardiff University, Wales, UK. The focus of my presentation is the skin. Specifically, I'll provide an overview of our largest organ and how this relates to skin health and skin integrity. Skin is the largest organ of the body and accounts for 15% of body weight. The primary function of healthy skin is to act as a barrier against chemical, physical, and mechanical hazards, and also invasion from microorganisms, as well as allergens. In healthy individuals, the skin is strong, resilient, and has a remarkable capacity for repair. Healthy skin performs a number of functions, including protection, where it acts as a barrier, preventing damage to internal tissues from trauma, ultraviolet light, toxins, pathogens, and allergens. It also acts as a barrier to infection. In addition to providing a physical barrier of intact skin, the presence of sebum, natural antibiotic chemicals in the epidermis, and a well-preserved surface acidic environment also helps prevent infection. Sensory perception from nerve endings within the skin respond to stimuli such as tissue injury, which causes pain, temperature, vibration, touch, and itch. The skin also has the capacity to regulate temperature, enabling either heat insulation or cooling of the body. Production of vitamin D in response to sunlight is important for calcium homeostasis and in developing and maintaining bone mass. Production of melanin, which is responsible for skin colouring and protection from sunlight radiation damage. In addition, the skin's outer appearance and capacity for sensation are important factors for well-being, self-esteem, cosmetic attractiveness, and communication. It also facilitates communication through touch and physical appearance, providing clues to the individual's state of physical well-being. The epidermis is the outer layer of the skin and consists of 5 layers. It repairs and regenerates itself every 28 days. The dermis consists of 2 layers, the papillary dermis and reticular dermis, which is composed of collagen, rectilium, and elastin fibers. It also contains a network of nerve endings, blood vessels, lymphatics, capillaries, sweat, and sebaceous glands, as well as hair follicles. The subcutaneous tissue, sometimes referred to as the hypodermis, is composed of adipose and connective tissue. It contains major blood vessels, nerves, and lymphatic vessels. It acts as a mechanical shock absorber, amongst other things. The histology slide on the right really shows the intricacy of the layers of the skin and helps to visualize the structure of the tissues. The outer epidermal layer is a barrier, preventing the evaporation of water from the body and absorption of water from the outside environment. The epidermis is divided into 5 layers as shown. The stratum basale contains the main cell type, the keratinocyte, which may be dividing or non-dividing. The basal cells then move upwards towards the surface and form a layer known as the stratum spinosum. This is where Langerhans's cells are found in this layer. Keratinocytes in the stratum granulosum contain a substance that plays an important role in the barrier function of the skin. The stratum lucidium sits between this layer and the stratum corneum, which is comprised of cells that have migrated from the granulosum layer, and the time from the cell division to shedding is around 28 days. The epidermis contains 3 main cells, the keratinocytes, which are protein cells, and they form the stratum corneum of the epidermis, which is the most superficial layer of the skin, vital for vitamin D production. And vitamin D, as we know, is associated with the uptake and metabolism of calcium. Dendritic cells are nerve cells, which are important for sensation, and melanocytes are pigment cells, which give skin colouring that protects us from ultraviolet radiation. The dermis consists of 2 layers, the papillary dermis and reticular dermis. It also contains a network of nerve endings, blood vessels, lymphatics, capillaries, sweat and sebaceous glands, as well as hair follicles. The dermis also contains a number of cells, including fibroblasts, which produce collagen, which is required for structure and strength. The endothelial cells are responsible for blood vessel formation or angiogenesis. The leukocytes provide an immune function. The smooth muscle cells facilitate contraction and relaxation of the tissues. And the extracellular matrix is an important component that completes the structure. At the stratum granulosum stratum corneum interface, the lamellular granules fuse with cell membranes and discharge their content into the intercellular lamellae. Complex enzymatic reactions lead to modification of the lipid composition of the intracellular space, including cholesterol, ceramides, and free fatty acids, which provide a very effective water-permeable barrier. Removal of the lipid component by repeated washing with detergents, soaps, and so forth can lead to conditions such as chronic irritant contact dermatitis. Transepidermal water loss is the rate at which water vapour is lost from the skin. In a healthy state, the epidermis can resist the assault of external irritants to protect the skin integrity. However, in the presence of continued external irritants, damage to the skin barrier occurs, leading to water loss from both the dermis and epidermis. The consequences of repeated assault is shown in the diagrams. Therefore, it is important to maintain the protective acid mantle and skin lipids to reduce risk of dryness and damage. The optimum pH of the skin is 4.5 to 5.5 to protect the acid mantle, the purpose of which is to shield the epidermis from bacteria and pollutants. It also helps to regulate the skin's natural sebum and water balance. This mantle is comprised of perspiration as well as oil from the sebaceous gland. A higher pH, i.e. a more alkaline environment, breaks down this protective mantle, allowing bacteria and external irritants to enter the tissues. There are a number of factors that can lead to the skin becoming vulnerable and at risk. For example, age, ultraviolet radiation damage, genetic conditions such as ichthyosis or dry skin, some medications and irritants from dressings, maceration from incontinence and repeated skin cleansing. These factors can be classified as extrinsic and include environmental damage such as regular soap use, sun exposure or smoking, or indeed pressure. Factors can also be intrinsic such as skin conditions, including psoriasis and atopic eczema, or underlying illnesses. Additionally, these factors can be modifiable or unmodifiable, which is something one of my fellow speakers will be discussing shortly. I just want to focus on age as one of the factors affecting skin health. As this is an intrinsic factor, it is much more difficult to address because the normal aging process causes skin changes that make it more fragile and susceptible to damage. And this is due to thinning of the epidermis, loss of collagen and elastin, and also overall loss of moisture. Acknowledging that there are physiological changes that may not be reversible, there are a number of strategies that can be employed to optimize skin health and maintain integrity. Again, one of my fellow speakers will be discussing this in the subsequent presentation. In summary, there are a number of key take-home messages from this presentation, which include: in health, the skin is strong and resilient. The primary function of the epidermis is as a barrier to protect against external insults. The dermis supports the epidermis and provides mechanical strength. Maintaining the barrier function and acid mantle of the skin is vital for skin integrity. Healthcare professionals need to be cognizant of the factors affecting the skin in order to optimize skin health and integrity. So therefore, my call to action to you is: skin matters, look after it. Thank you for listening. Remember, if you have any questions arising from the presentation, you will have the opportunity to take part in the live Twitter chat. You can also follow us on Twitter @SkinTears. You can also contact any of the iStaff members via our website, www.skintears.org, using the email address info@skintears.org. I'm just going to do that last slide again. So, in summary, there are 12, So in summary, there are a number of key take-home messages from this presentation. In health, the skin is strong and resilient. The primary function of the epidermis is as a barrier to protect against external insults. The dermis supports the epidermis and provides mechanical strength. So maintaining the barrier function and acid mantle of the skin is vital for skin integrity. Healthcare professionals need to be cognizant of the factors affecting the skin in order to optimize skin health and integrity. So my call to action to you is that skin matters, look after it. Thank you for listening. Remember, if you have any questions arising from this presentation, you will have the opportunity to take part in the live Twitter chat. You can also follow us on Twitter @SkinTeds. And you can contact any of the ISTAP members via our website, www.skinteds.org, using the email address info@skinteds.org. Thank you.
Hello, this is Diane Langemo speaking to you from the United States, and I'm going to be speaking to you about how ISTAP went about developing a risk framework for skin frailty. ISTAP and the International Consensus Panel on Skin Frailty met together in the United Kingdom in the fall of 2019 with a goal of developing best practices for skin frailty. ISTAP is an international interprofessional collaboration that's dedicated to improving the outcomes for individuals who are at risk for or who are experiencing a skin tear. The goal was to develop a holistic, individual-centered, evidence-based approach using an integrated strategy. And we were very intent on the best practices needed to be based on the best evidence in the research literature. When you think about frailty, there are multiple synonyms and definitions that come to mind, but the most common ones would include weakened tissue, weakened body, weakened organs, which then could put you in a very vulnerable condition. It's associated with age and it's associated with delicate skin. And all of these together impact on and are impacted by a lack of homeostasis. The actual term of skin frailty is an umbrella term, and the definition is, quote, represents a risk or threat to the skin, not necessarily a wound or break or disruption in the tissue. It affects all ages, particularly the extremes of age, the neonatal and especially preemies, as well as older individuals as their skin gets drier, less elastic, thinner, and more vulnerable to breakdown. And it's known to be multifactorial. So we are aware that it represents the concomitant interplay of multiple factors: physical, psychological, social, environmental, and economic factors. And many different things impact this. Just a few examples: aging, undue exposure to the sun, your genetics. Were you born with dry skin? Were you born with oily skin? So as you age, and from day to day and even hour to hour, it's a dynamic and ever-changing state. It can be very transient and it can be chronic. So skin frailty, we know, is multifactorial, and it has a multitude of risk factors that have a cumulative effect on the individual and their skin health. There are many, many intrinsic and extrinsic factors. So over the lifespan, your vulnerability to the skin being injured can be increased or it could be decreased. So at any given point in time, you might have more or less likelihood of skin problems. The development of a risk framework for skin frailty definitely would be focused on prevention. And for the framework, we were defining the concepts related to skin vulnerability, and then we're defining the holistic methods that will help maintain and promote skin integrity. So when we were developing the risk framework for skin frailty, we definitely were considering the concept as encompassing an integrated focus that focuses on the individual's skin health holistically and incorporated a synergistic risk factor focus that was linked to the individual's overall health and well-being. And I'll say more about this in a minute. Many different conditions relate to skin frailty, but the primary ones are skin tears, pressure injuries, moisture-associated skin damage, and skin changes at life's end or scale as it appears in the literature. So we know full well that there are other conditions that relate to skin frailty, but these four that I mentioned are the ones that have the strongest evidence in the literature. So again, we know it's a synergistic relationship between all these factors, and our goal is to optimize them for the best outcomes for the patient to ensure that skin health is the focus and that it's maintained, and the risk to all of these factors can thereby be reduced. So this is a pictorial description of what I was just talking about. We want a holistic approach, we want it individual-centered, and we want to use an integrated strategy. For example, as one ages, your skin becomes drier, thinner, less elastic, as I mentioned before. If you are living in a very dry environment, your vulnerability in that area and those older individuals will be increased. If you're living in a more humid climate, that risk to the skin from dryness could easily not be as great a factor as it would be in a dry climate. So skin frailty, as we know and have described, is complex, it's multi-dimensional, and it varies from situation to situation. So we want to have the optimized outcomes for each individual, and that can happen when we address the individual needs and preferences, the intrinsic and extrinsic factors, do an assessment and evaluation on an ongoing basis, and develop and implement an evidence-based, person-centered, individualized approach. The components of skin frailty, which are going to be discussed in far more detail in the rest of this webinar, include assessment, skin care, and self-care. And all of these are based on the frailty framework and recognition and implementation of the best practices. So thank you for your time, and the next presentation will occur very shortly. Thank you.
My name is Gulnaz Tariq, and I'm the president for International Interprofessional Wound Care Group, and I'm president for World Union Wound Healing Society Conference. I would like to talk to you today about the focus on promoting skin health and skin injury prevention, which is part of best practice recommendation for holistic strategies to promote and maintain skin integrity. Before I go further, I would like to thank the team of International Skin Care Advisory Panel and all the key opinion leaders who were part of this document. And I would like to thank Wounds International to provide that platform in UK where everybody was sitting together and making this happen. Thank you very much. So to do this, we have to focus on promoting skin health and skin injury prevention. We have to really look into the optimal skin health, particularly in individuals with vulnerable skin. This is the importance key, which is for optimizing skin integrity outcomes. And it is also widely accepted that the importance to take into consideration the overall picture of individual Example, their mobility, their nutritional status, their socioeconomic and psychosocial factors. Key components of the comprehensive skin assessments are patient medical history. Does the patient have intrinsic risk factors for vulnerable skin, such as old age, diabetes, or any other disease, underlying disease, or the thin skin? We also have to have the consideration if the skin is intact. Does the patient have wound-related risk factors such as varicose, eczema, infection, high level of exudate, excessive moisture, edema, or pitting edema kind of things? Then we have to look into, is there a skin condition present? Is there anything unusual which as a rash or dryness? Or is the skin sore or itchy? How does the skin feel to the patient? Then assessment of the patient knowledge about his or her condition, also a key for comprehensive skin assessment. So when we do the skin assessment, we have to look into how long has the patient had this condition? How often does it occur? Are there seasonal variations? Is there a family history of skin problem? Could the patient occupation, hobbies affect their skin? What medication patient is on, particularly long-term medications such as corticosteroids? Are there any known allergies? Is there exposure to any other extrinsic risk factors? For example, increasing sun exposure, smoking or alcohol intake, previous and past treatments and their effectiveness. Are there any treatments, actions, or behavior that influence the condition? Is there any order present for the skin condition of the patient? The key components of comprehensive skin assessment also include apply gentle touch pressure to the skin to gather information about the skin texture. Using your fingertips, check the temperature of the skin, and we advise to use infrared thermometer to check the skin temperature. Ideally carry out the skin examination in a warm private room, and in our location, because we have humid weather, so we prefer to have comfortable room temperature. If an individual is deemed to be at risk, the risk reduction program checklist should be implemented, and that is inspect skin and investigate previous history of skin frailty. If patient has dry, fragile, or vulnerable skin, assess risk of accidental trauma. Manage dry skin and use emollient moisture to rehydrate limbs twice daily or as required. Implement an individualized skincare plan using skin-friendly cleanser. Prevent skin trauma from adhesive dressings and tapes. Consider medication that may directly affect skin. Be aware of increased risk due to extreme of age. Discuss use of protective clothing, example, long sleeves and retention bandages. Avoid sharp fingernails or jewelry during patient contact or inspection. Then for mobility, we have to encourage active involvement or exercises for physical function if it's impaired. Avoid friction and sharing using the glide sheets and hoist for turning regimes. Conduct fall risk assessment and put the prevention protocols. Ensure that sensible, comfortable shoes are worn. Apply clothing and compression garments carefully. It shouldn't be that tight that it will cause pressure to the patient's limbs. Ensure a safe environment, adequate lighting, and removing the obstacles. Use padding for equipment as per local policy. Assess potential skin damage from pets. And other factor which you will look into it is the general health of the patient. So you need to educate patient and carers on skin frailty risk and damage prevention. We have to actively involve the patient into the care and the carer when we're making the decisions. Optimize nutrition and hydration, referring to dietitian if that is necessary. Refer to appropriate specialists if impaired sensory perception is a problem. Consider possible effects of medication and pharmacy on the patient's skin. For skin care, regular moisturizing should be viewed as a vital part of skin care in individuals with frail skin. This can help to restore the barrier function of the skin and reduce itchiness and increase the level of hydration. The benefits of moisturizing to treat specific skin conditions are well recognized, but in patients at risk of skin breakdown, this should also be used as part of a full everyday skincare routine. The other thing which you will consider is moisturizing products which are available in various forms are creams, ointments, and lotions, as well as liquid wash and gels, which should be having pH balance. So the pH balance should be between 4.5 to 6.5. Other factors should also be considered when caring for at-risk skin, such as reducing sun exposure, minimizing frequency of bathing, taking care that water temperature is not too hot, and patting the skin dry with a soft towel rather than rubbing. The use of suitable products should be incorporated into a standard approach to skin care to aid with moisture management. The other things which you will look into it, so it is recognized that excessive moisture is damaging. However, replenishing natural moisture is important and can be accomplished through applying moisturizers, making sure that these are used appropriately and do not risk additional maceration. Importantly, excessive moisture should not be seen as an implementation barrier to using moisturizing products, as these serve to protect the skin and improve its overall integrity. A protective barrier is recommended to help prevent skin from further breakdown. So in suitable individuals, moisturizing can be incorporated into the individual's own daily routine. For example, they can be instructed to apply emollient or moisturizers themselves to increase an existing moisturizing routine and optimize their own bathing regime to incorporate suitable skincare measures that will reduce risk of damage. It is also important that the holistic view is taken on self-care, ensuring that the patient is as healthy as possible. Nutrition and hydration are the key to skin health and can help to prevent skin damage. Mobility should also be encouraged wherever possible, and a self-care checklist can be given to encourage patients to monitor their own skin health and holistic well-being. So polypharmacy issues should also be taken into consideration where necessary, and as some medication can cause changes to the skin that need to be managed appropriately. So this is the checklist which we have to give to the patient, and he has to check with this checklist on a daily basis. So the key points for skin damage prevention is holistic assessment and ongoing monitoring of individuals are the key. Emollient therapy should be part of daily regime for individuals with fragile at-risk skin. Self-care should be encouraged wherever possible, which can increase engagement with treatment and improve outcomes. A pH level of 4.5 to 6.5 should be maintained to preserve the acid mantle. Thank you very much. Again, thanks the whole team of ISTEP and all the key opinion leaders who were contributing to make this document available. Thank you very much indeed.
Hi, my name is Kimberly LeBlanc, and I am the Academic Chair of Nurses Specialized in Wound, Ostomy, and Continence, Canada. I am a past president and one of the founding members of the International Skin Care Advisory Panel. And it's my pleasure to be with you today to speak to you about the holistic strategies to promote and maintain skin integrity and changing practice. So what I want to talk to you about is actually skin tear reduction. So we know that from the ISTAP material that in order to have a comprehensive skin tear reduction program, we need to make sure we implement such a program. And this should include prevalence and incidence studies to occur as regular audits, as well as using a validated classification system and developing a consultative team. But the big question is, how are we going to implement change, and how are we going to implement this into practice? So first of all, let's take a step back and talk about what is program implementation. So implementation is the carrying out, execution, or practice of a plan, a method, or any design for doing something. And if we're looking at knowledge translation, that's the action of moving knowledge into practice. So why do we need to know about knowledge translation? Well, sadly, we know that 1/3 of patients do not get treatments of proven effectiveness. Up to 3/4 of patients do not get the information they need for decision-making. And 1/4 of patients get care that is not needed or is potentially harmful. And up to 1/2 of healthcare professionals do not get the evidence they need for decision-making. So this tells us we need to do a better job of moving knowledge from the research into practice. So there's 2 things that we need to do in order to achieve knowledge translation. First, we need to create the knowledge, and then we need to apply it. And certainly there's been teams of researchers from around the globe who've been building the body of knowledge around skin tear management and prevention. So now our job is to actually apply that knowledge. I like the knowledge to action framework as a means of helping to guide how to implement a program into practice. So we've already created the knowledge. So now our first step is to identify the problem. So we start with a needs assessment, and I'm going to use an example of a team that I recently worked with here in Canada. So the nurses in a long-term care facility or nursing home recognized that they thought skin tears were a problem. Their prevalence was 18%. So the nurses came to myself and NSWOC, our nurse specialized in wound, ostomy, and continence, and their management. The registered and non-registered staff, their residents or patients, and families were interviewed to understand their perception of the problem and their commitment to prevention. Support from facility management and administration was secured, and commitment to reduce skin tear prevalence and improve resident care. So once we've identified the problem, then what we need to do is look to see what kind of programs can we implement. So one of the first things is we find a program that we like, but then we need to see, can we adapt it to our local context? So we know that guidelines provide evidence in a more usable form for practitioners in healthcare settings than primary studies. However, an important additional necessary step is taking that guideline and adapting it to clinical practice. So what we did in the long-term care facility was we took the ISTAP skin tear toolkit for prevention and management of skin tears. And the first thing that we did with that toolkit was look to see how would we need to adapt this to meet our clinical settings. So we assessed the guidelines for quality and currency, the content and consistency and acceptability and applicability. And then we had to decide and select the guideline to be implemented. So as I said, we chose the ISTAP toolkit for what we are going to implement in our facility. The next thing we needed to do was we needed to look at that toolkit to see what needed to be adapted to the local context. And part of that for us was looking at the product selection guide and adapting that, for instance, to our local context. So the next thing we need to do before we really get into implementation is looking at what are the barriers to knowledge use. So what things can help us move our project forward and what are going to be our barriers? Some of the biggest barriers tend to be around knowledge. So lack of awareness, lack of familiarity, or failure to keep up to date. Sometimes it's actually the attitudes and or motivation of the staff we're working with. So this could be due to where they don't have agreement in the scientific value of the evidence, they find that the guideline is too rigid, or they find it could be a threat to their professional autonomy, or there's a perceived bias of the author, meaning that they think that the person who developed the guideline was biased, so therefore the guideline isn't valid. Some of the other barriers come down to costs associated with the program. So in our case, we look at the costs associated with the prevention products and treatment options. So these were administrative and management barrier. One of those things was the twice daily application of moisturizers. So this, once again, was a barrier. It could be for residents, it could be for our staff, but it could also be from a cost perspective. We also looked at minimizing bathing, and we knew that our residents and their families could propose barriers to this. And then we looked at the potential knowledge gaps, which would be all of our stakeholders, that lack of awareness, or what we call sacred cows, in case where they say, well, we've always done it this way, but it's not necessarily the best way to do something. But what we had for facilitators was we had a desire by all stakeholders to improve care and decrease prevalence of skin tears. We had the administration and the management support, and we had resident and family involvement. So we knew we had a lot of things that could actually facilitate the implementation of a program. The next step is selecting, tailorizing, and implementing the interventions. So this is where you have knowledge translation interventions that need to be tailored to specific barriers for change, similar to a clinical treatment tailored for a diagnostic health problem. So in our example, the nurse-directed wound care team worked with management to determine how to overcome budget issues while at the same time preventing skin tears. It was important that we link knowledge translation and intervention with barrier to knowledge use. So for knowledge, we knew that some of the staff were working with out-of-date knowledge to provide care and prevent skin tears. The staff displayed multiple different educational levels and learning styles. So for our intervention, we had to use various forms of information and delivery methods to adapt the information to those individual needs. So we actually did classroom work, hands-on, web-based, focus group meetings, and we used staff champions as well. So if we look at some of our interventions that we could do, we looked at our educational interventions where we did interactive lectures, small group learning, self-directed learning, and continuing educational opportunities. It was also important that we had feedback for these interventions. So we did needs assessments, chart audits, interviews, and we elicited feedback from the participants. From an organizational level, the interventions, we had to look at quality improvement, clinical practice guidelines, and care pathways. It's important that after we've put this knowledge into use and we've implemented our program, that we monitor the knowledge use. So we need to look at for the patients, measure their attitudes and use of resources through surveys and as well through other analysis, and for the healthcare professionals looking at the use of care pathways. Knowledge could be measured in terms of the impact on the patient, the care provider, or the organization. For in our example, we looked at prevalence studies to determine if the prevention program is successful in reducing the numbers of skin tears. And we had a reduction from 18 to 8%. We did patient satisfaction surveys, and we looked at the cost analysis. It's important that the impact knowledge use on healthcare professionals can be measured through questionnaires and interviews. We can look at satisfaction with practice and time for new practice. An example for our case was that we look at focus groups with registered and non-registered staff to discuss changes in practice and the impact that it had. We can also look from an organizational standpoint where we looked at the cost analysis, prevalence rates, patient satisfaction, staff satisfaction, and meeting our ministry guidelines. Next thing that we have to look at is that sustained knowledge use. We want to make sure that our program is sustainable over time. So sustained knowledge use refers to continued implementation of innovations over time. It depends on the ability of workers and organizations to adapt to change. And we know that sometimes tension can exist between what's routine, so the routineness of one innovation and the repetitiveness to subsequent newer innovations. So it's really important that we make sure that we're adaptive to change and we're ready to continue to change over time. And we look at factors that really influence sustainability over time. And these include the relevance of the topic, benefits, attitudes. But what I find is some of the bigger issues are the leadership, the policy, the financial aspect, and what's happening politically in your environment. So it's very important that you keep an eye on these factors and make sure that you have the continued support. And one of the other things that really helps sustainability is to make sure that you celebrate your successes along the way. Make sure that the team knows that you appreciate them and show them the good work that they're doing. So in summary, we know that skin tears are a burden for today's healthcare professionals. We know there's a need for implementation of a sustainable reduction program. So this is our call to action to you to implement your own skin tear reduction program.
Thank you very much to all the speakers for their excellent presentations. And it is an honor to provide some closing remarks to this webinar. There is an imperative for improving skin integrity outcomes in individuals with frail skin. As I said in the beginning, the skin is the largest organ. It has multiple functions, and it is so important to overall health. A holistic, person-centered approach to skin health can break down care silos, and it can improve skin integrity outcomes and the quality of life in those with skin frailty. Essential elements in this approach to skin care include thorough, holistic assessment and continued monitoring, consideration of multiple interrelated factors that encompass individual need and preference, general health status, mobility, nutrition, continence status, and socio-economic and psychosocial issues. It is clear from the presentations today that there is a need for an increased awareness about the skin and its importance to overall health in specific patient groups who may be at risk of skin damage due to their general frailty. The skin is a vital organ and it should be treated as such. And this is also important as an indicator of overall health and well-being. While we have focused on specific conditions and their synergistic risk factors, there are many more. There is also a huge scope for individual involvement from patients and their carers and their relatives. Self-care regimens in at-risk individuals have been found to have a beneficial effect on outcomes, both in terms of patient health and quality of life, and as a relatively low-cost way of improving systems and making cost savings. This new approach should encourage a way of thinking that encompasses all aspects of skin health, viewing skin issues through the lens of skin frailty rather than as separate conditions. This should, in turn, improve outcomes and, most importantly, for the individual. I would like to thank you very much for attending and participating in this virtual event organized by the International Skin Tear Advisory Panel in collaboration with WUWHS International. Thank you very much.